Hello, folks. Welcome to today's session. So today's session had to be done on Tuesday as Dr. ANOOP Kumar was not free on Sunday. The topic today is BIPAP, the small portable ventilators that we have. And Dr. ANOOP Kumar had taken a couple of sessions earlier also on ventilation for us. He is Director of Critical Care Medicine for Aster Group of Hospitals, North Kerala cluster. So we'll take the questions in the end. Over to you, Dr. ANOOP Kumar.
Thank you, Doctor. So today, in this session, we'll be discussing on non-invasive ventilation. As you all are aware, this non-invasive ventilation is a very important and basic topic as far as ICU management is concerned. So in today's session, we'll be discussing on the different modes of non-invasive ventilation, and how non-invasive ventilation supports the patient breathing, the basic concept, and how a ventilator responds to the patient effort, so how we can optimize that, and some common terminologies like IPAP, PEEP, pressure support, inspiratory time, TI minimum, TI maximum, etc. And we have positive, the pressure preset and volume preset, as you all know. So in majority of the BiPAP ventilators or non-invasive ventilators, they usually use the pressure preset or the pressure control ventilation, where the pressure will be constant and the volume will be changing. So coming to the circuit, the basic part. So the main difference between an ICU ventilator and the non-invasive ventilator is this is a single limb circuit. So you have the gas coming in from the ventilator, and the gas is the air along with the oxygen is going to the patient. The patient inhales that, and now when the patient exhales, you need some pod for the carbon dioxide exhalation. So those things are happening through the vents here in the mask. So this type of mask is called a vented mask. So here you can see the hole here. So whenever you feel with your dorsum of hand, you can see the gas leaking out through this port. So the exhaled carbon dioxide is leaking through this thing, and for the exhaled gas to come out through this vented port, you need a constant pressure or a constant flow to push this exhaled gas out. So that is maintained by the pressure during the expiration or the EPAP. So you need a basic EPAP of at least 5 centimeters when you are using an NIV, because you need that pressure to push out the exhaled gases. So that is a common doubt we all have. Suppose if the patient is having a CO2 retention, type 2 respiratory failure, why we need an EPAP? An IPAP is enough so that you can have a higher pressure support and higher tidal volume. So that concept is completely wrong. As I've already mentioned, you need a continuous pressure to push the exhaled air out. And another thing, suppose if you don't have a vented mask like this, you have an option of connecting a leak port to the mask. So whenever you connect a leak port to the non-vented mask or the mask without leak, you can get the leak around this port, or here also you can get the leak around this port. So I've seen people who are just obstructing this port with some plasters, Dynaplast, etc., thinking that the air is leaking out. It is not like that. If you are using a non-vented mask, you need a leak port, and this is called the leak port. So never try to obstruct that leak port whenever you use it through a single limb circuit. I think that part is clear. Suppose if you are using a ICU ventilator where you have a dual limb circuit, so you have an inspiratory limb and an expiratory limb. So here the gas is moving through the inspiratory limb to the patient. Then, sorry, 1 minute. Then the exhaled gas is coming out through the expiratory limb. So you have an inspiratory limb, gas going in, then patient exhales, and the gas is going out through the expiratory limb. So here you don't need a leak port here, or whenever you use a dual limb circuit, you have to use a mask without a leak port, and this is called as a non-vented mask. The same way, how to like connect the patient here, like the machine should be connected to the plug, and you can use an HME or a filter here, or you can connect it towards the patient as well. So here again, we can modify the circuit like during the COVID time and what you might have seen. Suppose if you are using a non-vented mask here, or if you are ventilating using a non-invasive ventilation for a infected patients, like or the patients with an airborne infection like pulmonary tuberculosis, COVID, H1N1, influenza, etc. So here the exhale gas will be having the viral particles. So that can infect the healthcare workers. So what you can do is you use a non-vented mask here. So there will not be any leak. Then you put a combined HME viral filter here. Then after that, you can connect a leak port. Clear? So first non-vented mask, the filter, then you use a leak port. So the gas is coming out through the leak port will be filtered through the filter what you are keeping here will be having a lesser viral or bacterial content in that. So that is the way you can reduce the pathogen load in the exhaled air. So now coming to the respiratory cycle, here you can see the respiratory cycle are having a different part. You have this blue is called an inspiratory part, and you have an expiratory part. So here in the inspiration, it is inspiration like starts after a triggering. After the triggering, there is an inspiratory phase. Then the inspiratory phase ends, or this term is called the point from where inspiration changes to expiration, that is called as a cycling. So from the inspiration, it is cycling into an expiration. So initially there is a trigger, then there is an inspiration cycles to expiration, and so that is the complete cycle. And again, you have different pressure here. So the basic pressure what you are keeping is called as an EPAP or positive. It is a similar terminology for our positive and expiratory pressure in our normal ventilator. So you have a EPAP or PEEP. So instead of PEEP, we call it as a EPAP. So that is the pressure above the baseline, which is continuously present even during the expiration. I've told the use for EPAP. One thing is, just like the PEEP, it will recruit more alveoli and it can improve the oxygenation. The second use here in NIV is, this is the pressure or the flow which helps the exhale carbon dioxide to push out. So you need a basic EPAP. And in a patient with obstructive sleep apnea and all, the EPAP is the one which splints the airway and keep it open. So these are the three uses of an EPAP in an NIV. And you have an IPAP. So IPAP is basically the pressure support, or the difference between EPAP and IPAP is called as the pressure support or the delta P. So if you increase the IPAP and EPAP difference, then we can increase the pressure support just like our CPAP pressure support mode in a ICU ventilator. Okay, so this is the difference between IPAP and EPAP is called delta pressure. That increases the pressure support. So if you want to wash out more carbon dioxide, sometimes you will have to give more delta P. For that, we can increase the IPAP. So this is the pressure support part. Now we have something called as the ramp or rise time. So this is from the baseline flow to the maximum flow. How much time is taking? This is called as a rise time. So if you keep the rise time minimal, then the inspiratory flow is attained quicker, or the patient can the patient can reduce the inspiratory time. In other words, so if you want the flow to happen so fast to the complete level, you have to keep the rise time minimal. So rise time minimal means you reach the flow fast. Then we have something called as TI minimum. Then we have something called as TI. Then we have something called as TI maximum. So this concept you should be very clear. So what is TI? This is called the inspiratory time. So if you are keeping the patient on a like timed mode, or if you are keeping the patient on a mode called PAC mode, so here the inspiratory time is always constant, and the ventilator will switch at inspiratory time to the expiratory phase, or it cycles at TI to the expiration. So the TI is constant in PIC mode. Then what is TI minimum? So TI minimum is the minimum time the patient has to hold the inspiration. So suppose if the patient wants to terminate the inspiration at this point, the machine will not allow that. The machine will hold it up to the TI minimum. The same way, if the patient is continuously keeping the inspiration for a quite longer time, patient cannot breathe it more than the TI max, because beyond the TI max, beyond the TI max, patient cannot hold. So TI max is the maximum time the patient can keep inspiration, and TI minimum is the minimum time patient will have to keep the inspiration. Okay. So suppose if you are ventilating a COPD patient where you want to reduce the inspiratory time, so or you want to keep an IE ratio more towards the expiration, then you have to keep TI minimum to the minimum value and TI maximum also to the minimum value. And the I time will be cycling between TI minimum and TI maximum depending on the patient effort. Then you can ask me why you need TI minimum and TI maximum, why can't only TI? So this is a spontaneously breathing patient. So this is the way you can adjust the IE ratio by adjusting the inspiratory time. Okay. So the patient is taking the inspiration, but the inspiratory time can be modified using this TI minimum and TI maximum. I think that part is clear. Then you have the next component, which is the one breath cycle. That is including the inspiration, and the expiration is called as the one breath cycle. Inspiration plus expiration. Okay. So now moving on to the common modes what you are using in the non-invasive ventilation. So this is also very, very important slide. Please listen to this carefully, and if you have any doubt, you can text during that time. The first mode is called as the CPAP mode. The CPAP mode is usually used in obstructive sleep apnea, and you need only a very basic ventilator for this thing. Here you need all the patients are breathing spontaneously, and you have different the ventilatory modes like CPAP. You have spontaneous mode, you have ST mode, you have PAC mode, and you have T mode. So these are the common modes available in the NIV: CPAP, spontaneous timed, PAC, and T. So now we'll see what are each modes. Coming to the CPAP mode. So here the CPAP mode, you can see there is no triggering and cycling by the machine. So here this is the patient effort. Patient will be breathing, and a continuous pressure will be applied during both inspiration and expiration. So this is called as the CPAP. And the respiratory flow depends on the patient effort. Patient can change the inspiration, expiration, effort, everything. There is no effort or support by the machine. Okay, the machine will be giving a continuous flow. So this is usually used in obstructive sleep apnea to split the upper airway and to reduce the apnea or sleep apnea. Okay. Now coming to the next mode, the spontaneous mode, which is very commonly used. So here, majority of the time, you are setting the EPAP and IPAP, and this is the pressure support. Depending on the pressure support, the tidal volume will be varying. And here, this is the one breath. The patient actually initiate the breaths. The patient only terminates. So the initiation and termination can be done by the patient. So here also, patient is the one who initiates. Patient only terminates. Suppose here in the next one, so you can see like the patient is actually prematurely trying to terminate. So in this point, the TI minimum function will act, and the patient will be, the inspiration will be continued up to TI minimum. You have to listen carefully. Suppose if the patient is trying to terminate it before TI minimum, the machine will hold it up to TI minimum. So the cycling is done by the machine using the TI minimum component. Suppose in the next part, if the patient is continuously holding the inspiration for quite long time, the TI max function will function and at TI max point, it will cycle from inspiration to expiration. So the TI max will limit the inspiration at TI max. TI minimum will limit the or will prolong the inspiration up to TI minimum. Okay, and the trigger is by the patient, and the cycling is either by the patient or by using the TI minimum or maximum function in spontaneous mode. Now coming to the ST mode. So here it is same as spontaneous mode. The patient triggers, the inspirate TI minimum, TI maximum function is used. But the only difference here is you can see, suppose after triggering 3 breaths, patient is not triggering for quite long time. So you have set a minute, suppose you have set up a minimum rate of say 20 or 15. So even at that window, 15 means every 4 seconds, one respiratory cycle will be 4 seconds. So in that 4 seconds, if the patient is not triggering a breath, the machine will trigger a breath, and it will be terminated at TI minimum. Okay, so whenever the machine triggered breath is there, it will be terminated at TI minimum. Okay, then the patient takes and it is going up to TI maximum. So here again, whenever there is the machine triggered breath, so that will be terminated at TI minimum. Okay, so this is the ST mode. So here patient will be spontaneously breathing, but you can maintain a minimum rate by setting the respiratory rate along with the other components. Now we have a beautiful mode called PAC mode, otherwise called pressure assist control mode. This is not commonly seen in all the ventilators. The picture which I've already shown, like the Stellar 150, some of the other higher NIV ventilators, all are having this PAC mode. So here you can see what I've told. All the breaths are terminated at TI minimum. Patient cannot breathe, cannot stop beyond TI minimum, before TI minimum, or cannot take it more than the TI minimum. So this is TI minimum and maximum, both function is done by TI minimum. So all the respiration will be, all the inspiratory time will be of the same value, and almost tidal volume will also be of the same value. And here also it will act like an ST mode. Usually the patient will trigger. During that trigger window, if the patient is not generating a breath or not triggering, then the machine will trigger, and the machine triggered breath will end at TI. Okay, in the other mode, ST mode, the machine triggered breaths were ending at TI minimum. Clear? So this is about the PAC mode. Then finally we have the time mode. This is not usually used. This is only for the control mode, for a sedated sedated patient on controlled ventilation, or paralyzed patient on controlled ventilation, like during transport, etc. This is not usually done. So here the TI we are setting, and the patient cannot initiate the breath. There is no synchrony at all, or there is nothing like a trigger you can set. So the machine initiate, machine ends at TI minimum. Next breath at the same constant interval. Suppose if you are setting at 15 rate, every 4 seconds, the breath will be delivered. It will hold up to TI minimum, and next breath at another 4 seconds. So in between, even if the patient is breathing, the machine will not deliver much flow, and there will not be any pressure generation. Without any pressure generation, there won't be any tidal volume generation also. Okay. So the patient should be completely sedated and paralyzed. Otherwise, there will be the ventilator, patient ventilator asynchrony. Now coming to the ventilator per se. So here for the discussion purpose, we are using the Stellar 150 model of the resmed. So this is the resmed machine called Stellar 150. So each machine will be having different settings, but the basic concepts will be same. That is why I am using this screen. So here you can see like a Lang-like screen. So this is for the monitoring, and this is for the controls. And here you have another button, which if you press, you can see the alarms. And here you have a like a key, a lock-like thing. So if it is kept open, then you can do the settings. To do that, you can simultaneously press these two buttons, then it will open. Okay, continuously press these two buttons, the screen and the settings button, then the program will be opened and you can change that. Along with that, you can see whenever the power is connected, you can see this green button. When this shows the battery charge, how much charge is there, and what is the leak, respiratory rate, the tidal volume, minute ventilation, all those things will be displayed here. So if you keep on pressing this monitoring button, it will be changing into the next one. So this is the one for monitoring. That is the first page. The second page, if you press it again, it will show the leak, tidal volume, respiratory rate, minute ventilation, then the inspiratory time what we have kept, and the IE ratio. So this will be varying depending on the mode what you are using. So this will be showing these parameters like the second page, leak, tidal volume, respiratory rate, minute ventilation, then inspiratory time, IE ratio. If you keep that button again, it will move on to the third page, which is showing a pressure flow curve. Again, you can see how much is the pressure and flow happening. And in the settings button, if you go to this settings button, the tick button will help you to do the settings. So in this settings button, you can in the pathology part, you can either use a normal, obstructive, or restrictive. So if you go for a like normal, the settings, there will be some the preset values. Same way, if you go for an obstructive one, there will be some preset values. The same with the restrictive. And these all values can be modified as well. So if you are an experienced like intensivist who are able to adjust all these things, you don't have to make changes here. But if you are not that much experienced, if you can put an obstructive or restrictive or normal, that values will be slightly changing. And the next one will be for the mode changing. The different modes I've already changed, already discussed. Then the third one will be on the IPAP. You can set the IPAP. The fourth one will be on the PPAP. Then after that, for setting TA minimum, maximum, trigger, etc., you have to press the advanced setting. And in the advanced settings, you have different options of like learned circuit, then smart start, ramp time, start TPAP, maximum ramp time, etc. So what is this ramp time? Ramp time means, like, suppose if you are like ventilating a patient with a 8 TPAP. So from the beginning itself, if you start using an 8 TPAP, patient will be very uncomfortable. So here you set a start TPAP as 4. So patient will be starting from 4, and then gradually it will be building up to the set value, and that will be that you can adjust during the ramp time, or the maximum ramp time will also help you to gradually reach that level. The smart start will be another option where if you put it that on, the machine automatically will set this ramp time and gradually will build up the values. So now coming to one clinical scenario. So we have a 65-year-old patient who is a non-case of COPD, now coming with a severe breathlessness. It's a non-COPD, is FEV1 is 28% of the predicted. He is breathless and he is having dry cough. And on examination, he is tachypneic, respiratory rate is 29. There is an audible wheeze. Saturation is 95% on 60% of injury. And his blood pressure is normal, slightly on the higher side. Pulse rate is 100 per minute, but it's regular. He's using, you can see, he's using the accessory muscles for respiration. And this GCS is 13. It's acceptable. And the ABG is showing, what does this ABG indicates? He's having like a 7.27 pH and 76 PCO2 and 74 PO2 and a bicarb of 35. What does it indicate? So he's having a chronic type 2 respiratory failure. So how we are going to manage this patient? So you cannot manage any patient with NIV alone. So you will have to treat the patient. So here you are given a back-to-back nebulization of short and the salbutamol or levosalbutamol along with ipratropium. Then the steroid, it can be given either as an injectable or as a tablet. And in COPD, you will have to treat the infection because he's having history of cough, fever, etc. And you reduce the FiO2 to 24. You don't have to hyperoxygenate the patient. I'm not going into the theory of that. It is not to reduce the suppression of respiration, as you are well aware. It is because of some other mechanisms like the hypoxic vasoconstriction, then the Bohr effect, all those things. So mainly, basically, if you hyperoxygenate, the carbon dioxide transport and the hypoxic pulmonary vasoconstriction will get impaired, and that can again aggravate the CO2 retention. So this is the things now. The patient is 7.29. After the medical therapy, controlled oxygen therapy, even then the patient is having a CO2 of 72, and the patient is tachypneic as well. So from minimal 7.27 to 29, it has improved, but CO2 is still, it was 76 to begin with, now it is 72.7. So how we are going to manage? So obviously we'll be starting an NIV. So how an NIV is helping a COPD patient? So this is the concept. Whenever you have a NIV, so the pressure support will improve the tidal volume. I've already told you the whatever support, the difference between EPAP and IPAP will improve the tidal volume. So once the tidal volume improves, the patient's air hunger will come down and it will reduce the respiratory rate. Once the respiratory rate is reduced, your dead space ventilation will be reduced and it will improve the alveolar ventilation. And once the alveolar ventilation is improving, it will reduce the PaCO2. So your IPAP will help you to improve alveolar ventilation and reduce the PaCO2. And by reducing the PaCO2, your arterial pH will be getting stabilized. The EPAP what we are giving, it will reduce the intrinsic PEEP. So the triggering will be easier and the work of breathing will be improved. And other than reducing the intrinsic PEEP, I've already told, it will also help you to push out the exhaled carbon dioxide. So that is how the NIV works in a COPD patient. So how could you manage this patient? So here you will have to start the NIV, and the medical therapy with controlled oxygen will have to be considered. And whether you have to contact ICU and refer for intubation in invasive ventilation, not now. So there are many indications for NIV. So NIV should be considered in all patients with acute exacerbation of COPD in whom the pH is less than 7.35 and the PCO2 is elevated and persists despite of immediate maximum standard medical treatment. So that is very, very important. And the exclusion criteria are impending cardiac arrest, very low GCS, extensive facial trauma, a fixed upper airway obstruction, life-threatening hypoxia, and undrained pneumothorax. All these conditions, you should avoid that. And there are relative contraindications like the GCS is less than 8, and the presence of hemodynamic instability, etc. It should be continued only in a close monitoring. It can be used even in sick patients if you are not planning for intubation and if you are continuing with only NIV, and your plan of escalation should be very clear. And are there any other tests you would like to perform prior to NIV, whether you want to get a chest X-ray, CT vein and or peak flow? It depends on the clinical conditions. So what are your objectives in using objectives of NIV in using objectives of using NIV in COPD? First thing is decreasing the work of breathing. So how will you observe that clinically? There will be reduced respiratory rate, reduced use of accessory muscles, and improved chest wall expansion. Improved alveolar ventilation is the second one you are aiming. So there will be reduction in respiratory rate and improved oxygen saturation. Then the decrease in PaCO2. So it will improve the blood gas parameters and possibly the cognitive status will improve, and ABG wise you will be able to monitor that. correct the pH. So it will improve the gas parameters in ABG. So your objectives are reducing the work of breathing, improving the alveolar ventilation, decreasing the CO2, and correcting the pH. So these are the objectives when we are using an NIV in a COPD patients. So before you start NIV on this patient with the COPD, you will have to select the interface. Then how will you see like which is most appropriate? So majority of the time we'll be going with the oronasal mask. There are other methods like nasal pillar, nasal pillow, nasal mask, etc. But in a COPD patients, they may not tolerate that. They will be using, even there are helmet type of NIV mask. Again, that will not be very comfortable for COPD patients. And once you decided for an oro nasal mask, then how will you decide the facial mask? There is a caliper like this. So the caliper, the initial part should be kept it in the nasal cleft here. Then the second should be kept it in the chin here. So this is the point. So after keeping like that, see this mark, whether it is in the small, medium, or large size, whether this mark is corresponding to big size. Depending on that, you decide whether to use a small, medium, or large. So you have to always use this caliper to see which size of mask should be used. So here, as you can put it in the chin, you can see this patient is recurring. This mark is corresponding to M. There are different types of calipers by different companies. So whenever you purchase a mask, you can ask them for the caliper, and depending on that caliper, you can select the mask size also. And once this mask size is selected, you can explain to the patient that you are going to keep that, and you can gradually keep this mask initially. You hold the mask for initial some time, then you can gradually put the straps. Don't initially itself put the straps and then start the NIV. You can start with a lower pressure and gradually build it up, or you can use the RAM function to gradually increase that. So this is the way we put the strap. There is an upper part and a lower part. Now to reduce the pressure ulcers here over the nasal bridge, there are some the sticker like soft stickers or the nasal the protectors are available. So nowadays we use that also for all the patients so that it can avoid the injury here. And always try to use a good quality mask. If you are not using a poor quality mask with a higher pressure, the chance of the nasal bridge necrosis will be very high. So always use a good quality mask to avoid this nasal injury. So in acute exacerbation of COPD, what are the settings we are going to do? So one thing I've already told, you can go with an ST mode. An IPAP, you can go to 12 to 14. EPAP, you can do from 4 to 6, but don't go below 4 or 5 because of the chances of carbon dioxide retention. Don't have to keep a higher backup rate. You keep a backup rate of 12. And I minimum and maximum, you can keep it on the lower side. Roughly, you can keep TI minimum on 0.3 seconds, TI maximum to 0.8 to 1 second. And the trigger, you can keep it medium. So this trigger part also should be very careful. You have trigger high, trigger medium, and trigger low. So the trigger high means the machine will be able to trigger it very fast. The trigger low means the machine will have to generate more, or the patient will have to generate more pressure to trigger that. Okay, so it will be just the opposite, the numbers what you are keeping. Suppose if you are keeping a trigger high, it will be something like you keep a trigger of 1 centimeter. A trigger low means something like you keep a trigger of 4. Okay, and 2 will be something like a trigger medium. So whenever you go for a trigger low, the chances of triggering will be less, or the patient will have to generate more pressure to trigger. So this is the way you can use different settings as I've already told. So why all these things? What are the explanation? Suppose if you are using an ST mode, the patient will be comfortable, the patient will be triggering, and the patient will be cycling, but you will be able to adjust using TI minimum and maximum. The IPAP usually ensures sufficient unloading of the respiratory muscles to reduce the work of breathing and correct the ABG. So the IPAP, the difference between EPAP and IPAP is the one which determines the pressure support. EPAP usually helps to overcome the inspiratory threshold load for the intrinsic PEEP, and the backup rate ensures minimum ventilation level if the patient respiratory rate falls below the set level. So the backup rate will ensure a minimum ventilatory level, and the TI minimum and maximum, which we have already discussed. The trigger starting cycle sensitivity to high results in shorter inspiratory time, and the cycle, this is a trigger cycle, okay? Other one is a trigger sensitivity. The trigger cycling sensitivity high results in shorter inspiratory time and longer expiratory time, useful to ensure for the complete lung empty. And the medium trigger sensitivity or the trigger cycling is sufficient in the obstructive lung disease. And we have rise time, you can keep it 150 to 200 milliseconds, because usually you need a shorter inspiratory time and a longer expiratory time. So they require a faster rise and a faster fall. So you keep the rise time minimal, somewhere around 150 to 200. So here, this is the way you can use, like, so the patient is having, now the respiratory rate is coming, the BP is settling, the saturation is around 28 to 90%, and the respiratory rate is also 28. So you have kept it at ST mode, IPAP 30 and EPAP 3. Okay, and there is no much leak. Tidal volume is okay. Respiratory rate is coming down. Your TI is 0.5. Minute ventilation is adequate. And you can see the IE ratio is also acceptable. 1:3.4. And the machine is connected to the plug. Okay. And this is the advanced settings like TI minimum, maximum, the trigger, this is the trigger, and the cycling. Cycling, we kept it as high so that you need the inspiration will be cycled to the expiration fast. Okay. Rise time we kept it as 150. Fall time also we kept it as 200. I told in COPD you need a faster rise and a faster fall. And so this is the, now with these settings, you can see the patient saturation is improving. Okay, and the other parameters are improving. So to reduce the respiratory rate, what we have done, we have again increased the pressure support. So with the increasing pressure support, now you can see the respiratory rate is also coming down. The BP is also coming down, so that the patient is getting better. Okay, so this is how we assess the patient on ventilator. Okay, so suppose if you want to further reduce that, you increase the IPAP, then you can see the respiratory rate is again increasing. You can see this pressure flow curve in the third page of this monitoring. So you can see this. So this is the pressure between 4 and 7, and see the flow. So each one is triggered better, but here is also triggered, and the next flow it is getting triggered. But this part, there is a slight triggering issue. So why there is a triggering issue? See, these things are triggered well, but there is a triggering issue here. So what may be the problem? So this is a problem with the intrinsic PEEP. So here you can see like there is an alveolar constriction. The air is pushed in, and when the patient the exhales out, there is a resistance for the expiration, and as there is a resistance, the time taken for the expiration will be more, and during that time, if you push the air in again, there will be gradually an intrinsic PEEP developing. So at the end of inspiration, alveolar pressures remain positive, and the inspiratory muscle need to produce additional effort to generate the inspiratory flow. So patient need usually this much effort in a healthy lung, but in a COPD patient, as there is an intrinsic PEEP, patient need more effort. So to overcome that, you can give an additional PEEP, or this is called as an EPAP. So if you give a more EPAP, the triggering will be better. Okay. So now with these settings, you can see the ABG is improving, the CO2 is coming down, the patient is respiratory rate is also coming down. So now the work of breathing has reduced. That's why the BP and respiratory rate is coming down. The alveolar ventilation is improved. CO2 is improving, and your pH is also settling. Your all goals are met. Okay. So this is now you can see this triggering is also happening well. So initially there was a problem with the triggering. Now with the pressure flow, you can see the triggering is also fine. Okay. So these are the now like see the ST IPAP you have slightly increased. This is the backup rate. And here again you can see the pressure flow. It is happening. Triggering is happening nicely. So suppose like if you keep the cycle very high and the rise time 500, then the patient will be taking more time for the respiration to reach. Okay. So this is the one. See, this is the rise time if you keep minimal. So rise time setting alters the inspiratory flow rate. So here see, you don't have a proper inspiratory flow here. So if you want to give a more inspiratory flow, the shorter the rise time, the higher the flow rate, and the quicker the ventilator reaches the IPAP. So if you have a flow deficit here, see, if the flow is not happening properly, then you have to reduce the inspiratory time. So the long rise time and ineffective triggering in the pressure curve, there is no longer inspiratory plateau. The TI also has increased, meaning less time in aspiration, which may lead on to dynamic hyperinflation. So you will have to adjust it based on TI minimum, TI maximum, etc. So thank you so much. So with that, we have covered the basic topics. The same way you can use the NIV in a cardiogenic pulmonary edema or in a type 1 respiratory failure. There, the main difference is you give more EPAP. So when you give more EPAP, then you will be having, because of the reduction in the transmural, the pressure, the afterload will be reduced. Because of increase in the thoracic pressure, the filling will be reduced, or the preload also will be impaired. So that is how you can use it in the cardiogenic pulmonary edema. Same way in type 1 respiratory failure, you have to give more EPAP, so that just like the EPAP in the ventilator, more and more lungs will be getting recruited. So thank you so much. With these things, I hope I have given you an overview about NIV. This is a huge topic. Actually, if the time, if we would have if we were having a longer time, then we could have discussed the different case scenarios. Just go back and listen to the basic concept again and try to apply in your clinical practice. Thank you so much.
Thank you, Dr. ANOOP KUMAR. So just if you can stop the share screen. So very nicely elucidated, especially the basic settings and using COPD. So Dr. ANOOP, what about this thing, mild ARDS or early ARDS? Anything you want to say about the settings in those patients?
I've already discussed those things as well.
Okay. I may have missed her. All right. So friends, I will just say one or two points. First of all, the minimum difference between IPAP and EPAP should be 4. Okay, like something like it should, if it's 8 IPAP, then EPAP should be 4. The difference should be minimum 4. Otherwise, it goes into auto triggering. Second, the FiO2 is variable, and you cannot be sure of the FiO2. You can only get a rough idea. Third, what is the exit sources for the carbon dioxide? Since it's a single limb circuit, unlike a dedicated NIV ventilator where you have 2 limbs, right? So here, like sir told you, you can have exit through the vents or the ports in the mask. Second is there's always some leak. So when there's a leak, CO2 comes out. And third, even in the single limb tubing, some of the gas exits when you expire and CO2 gets washed out from there also. And a very important thing which Dr. ANOOP KUMAR sir had mentioned, that there's a difference between the settings on this BIPAP machine and the dedicated NIV. For example, 12 by 5 on a dedicated NIV ventilator is going to be 17 by 5 in the BIPAP machine. Okay, the difference between the IPAP and the EPAP is the pressure support on the BIPAP machine, while the actual number, that is if you set 12 by 5 on the dedicated NIV ventilator, will be pressure support of 12. So that is very important to realize. And in ARDS, because you have to have some element of PEEP, and if the CO2 is being retained, it becomes difficult to ventilate these patients in ARDS. It is more for acute hypoxemic respiratory failure, early stage, but a proper full-blown ARDS is very difficult to manage. But definitely it is very good for COPD and when you are going to wean off the patients also. So if there are any questions, we will take them. So if any questions, please let us know. So anything else you want to add, Dr. Anup?
No, if any questions are there, we can answer that.
No, I think that is all then. So thank you, Dr. Anup Kumar, sir. Thank you so much. And thank the audience for their patient hearing. Thank you so much.
Thank you.